Airway Clearance Guidelines by Christina Reed for Technology Applications in Health and Human Services. Having an airway clearance guideline and algorithm will help with the optimization of airway clearance on the respiratory patient. Guidelines and protocols can improve patient care, decrease the length of patient stays, decrease unnecessary procedures, and decrease the cost to hospitals. They can also improve the morale and worth of the respiratory therapist or the feel of the worth of the respiratory therapist. There are different indications for airway clearance, and these are based on each type of airway clearance. Some indications are the inability to clear retained secretions. Positive pressure can improve port lung expansion and atelectasis. Atelectasis caused by mucus plugging. A patient with a diagnosis of cystic fibrosis, bronchiectasis, muscular dystrophy, or spinal muscle atrophy, an ineffective or weak cough. Some contraindications for airway clearance are also based on the type of device that you have. Any kind of patient that is hemodynamically unstable, have uncontrolled hypoxemia aggravated by position change, hemoptysis, empyema or pleural effusions, any asthma pathway patients at Akron Children's Hospital, a patient with active tuberculosis, a patient with closed head injury and increased intracranial pressure, a patient with a bronchial pleural fistula or recent esophageal surgery, positive pressure especially on that one, or a patient with pulmonary edema. Some relative contraindications are fractured ribs, an untreated pneumo or bullous emphysema, you want no positive pressure, recent oral feeds, any post-op thoracic spine or abdominal surgery, chest or back burn grafts. These must be okayed per the surgeon. Some of the modalities are okay. A lack of a patient cooperation in positive pressure devices or devices that require a technique from the patient. A recent epidural spinal infusion, spinal surgery, or an acute spinal injury. Osteoporosis or osteomyelitis. Coagulopathy. Recent facial, oral, or skull surgery, any kind of mass therapy or positive pressure on the face, or tympanic membrane rupture. Currently, the order panel exists in the PICU EPIC program. All you need to do is type in airway clearance, and it'll pull up the airway clearance guideline order panel. It'll pre-select the airway clearance score, which will be ordered daily and PRN. It'll also pre-select to notify the physician and APP when changing the airway clearance frequency. And it'll pre-select to pick the airway clearance device. The ordering provider will still need to pick which device they like to use. What is not automatically pre-selected is any kind of suctioning. If the provider would like suctioning done PRN with the airway clearance, they need to select one of those options. Some of our available airway clearance devices are COP and deep breathing, which the patient does on their own, incentive spirometry, intrapulmonary percussive ventilation, or IPV, vest therapy, cough assist, OPEP, which could be the aerobica or a cappella, frequencer, chest physiotherapy, such as CPD, PD, or manual pounding, however different people refer to it, or the vibralung, which is in process and may be provided at a later date. So some providers may not be aware of which treatment would work better for different patients, so I made up this chart. If the patient is on no positive pressure or some sort of non-invasive ventilation or high flow nasal cannula, and they have a high score or a minimal cough, we would recommend vest therapy for them. And if they have a minimal cough, we would also include that with cough assist. But most therapies could be used, and they're put on this chart in order of effectiveness. If the patient has a chest x-ray with atelectasis and mucus plugging, just getting them up, moving them around, having them cough or take deep breath may be good for some patients. And then the vest therapy for some that may require some more invasive procedures. If the patient has an artificial airway, the go-to therapy should be IPV. And if the patient has a decreased cough, we should also add the cough assist to that. But anytime the patient has an artificial airway, the first go-to treatment should be IPV. Our airway clearance guidelines came about from another hospital. These were validated guidelines. Your patient assessment will translate into a score, and we will show you how that happens later. The score will dictate the frequency of therapy, and this will facilitate the weaning of unneeded therapy and increase the therapy when the patient is getting worse. Therapy will never wean below a patient's home schedule, no matter what the patient's assessment is. So if the patient has a home regime, we need to be aware of that and wean accordingly. Assessments will be done on day shift and PRN, and notifications to the provider via call, text, or page will be sent when the frequency is increased or decreased. And these also may require changes in the bronchodilator orders, since this is just an airway clearance guideline. If bronchodilators need to be given with the therapy, they need to be ordered separate. The airway clearance score will be documented in Epic under the RT assessment. You just put in the number of your score, and this will add it up, and there will be a note over to the side that you can see exactly what that translates into. The airway clearance guidelines score tool, if you have a score from 0 to 3, you can recommend to discontinue the treatment or put the patient on a home regime. A score from 4 to 7 is a Q12. A score from 8 to 11 is a Q8. A score of 12 is a Q6, and a score of greater than 12 is a Q4. If the patient is in PICU, there is the option of increasing the therapy to Q2 if the patient has failed the Q4-hour therapy. So this is a chart of the entire underlying score, which is a little bit hard to read, but it gives you an idea of everything that's included with scoring the patient. So a few things that you need to keep in mind when you are scoring a patient is, in report, you need to be very clear on why the patient is getting airway clearance therapy. You need to know the patient's home regime. If they do airway clearance at home and are admitted for respiratory distress, we need to make sure we score them a number 2 for an exacerbation of the pulmonary disease. Under Gestalt, you need to know what your patient's baseline is. Not all patients are alert and responsive to that baseline, so you need to discuss with their family or caregiver what their baseline is. Under activity level, if the patient is running around the room or going to the playroom, this is normal activity. If the patient is stuck in their room, you need to know if they are allowed to leave their bed and get up in a chair. And if they are sitting most of the time in their chair, they should be encouraged to get up and move if they are allowed to, and then scored appropriately. Or are they on complete bed rest? Respiratory rate should all be based on age. You should be very aware of what a normal respiratory rate for a patient's age is. And if the patient is on a baseline non-invasive ventilation, such as a BiPAP at night, you need to be very aware of what the patient is on currently. If the patient is only on their BiPAP at night and not experiencing any kind of increased settings or increased support, you can call them a non-ventilated patient. But if the patient has any increase in hours or any increase in support, then we need to score them as if they are mechanically ventilated. Any questions? You should see the education coordinator, or Chris Reed can answer any questions at Akron Children's. And here are some references that you can refer to also.